Hello and welcome everyone. Today we'll be discussing about the role of the rapid multiplex molecular syndromic panels like BioFire in critically ill patients. How we can use them, this is the expert guideline. New diagnostic tools like this BioFire should work alongside the traditional microbiology. They provide quicker results, but they do not replace our traditional methods like culture, which are still needed for more detailed analysis such as antibiotic sensitivity. So don't think that it is an alternative to culture. The results from these tools need to be reviewed by a microbiologist who has clinical experience to confirm the accuracy and the usefulness in managing the patient. For example, if the biofire detects Pseudomonas aeruginosa, the microbiologist checks whether the test's resistance marker match the local pattern and advises if this result is accurate or we need further investigations. So we cannot blindly use this test right now. We need it to be reviewed by the microbiologist, and only after their confirmation we are to use it. Next is, these tools help in diagnosing infections quickly and precisely. They guide doctors in choosing the right antibiotic and avoiding unnecessary or ineffective treatments, particularly in case of MDRs. So in this, the example is, say a patient is having a VAP and he is deteriorating, and you find that it is Klebsiella, which is carbapenem resistant. So you immediately start the treatment for carbapenem resistance instead of waiting for 2 to 3 days for the culture results. The next is, it is not necessary to repeat these tests unless the patient condition significantly changes. Doing unnecessary tests can lead to wasted resources and confusion. For example, if the patient in the ICU is on antibiotic and is stable, there is no need for me to send a biofire right now. So, and if the patient is improving with the current antibiotics, again, I don't need to send the biofire. So, don't do these tests when you do not have any endpoint for this. So, you must have a clear view or path in your mind that once you get the report, this is the change in my management. If my management is not going to change, I will not going to waste the resources. So if a patient already has a recent positive microbiology test, these tools just to rule out infection isn't usually helpful unless absolutely needed. So there is absolutely no need to do tests where you already have a positive microbiological result. The results from these tests should directly influence your treatment decision. As I have said in the point 4, it must change your treatment decision, like starting a new antibiotic, stopping an antibiotic, or adjusting the antibiotic. So the example that I will give over here is, say the biofire identifies Acinetobacter baumannii, which is resistant to colistin. So we will manage our combination based on this information immediately. Now, whether I should stop or not the antibiotics will be based on the clinical decision, especially if it is a patient in septic shock and I get that there is no growth, even in PCR. Then I must evaluate that based on the patient's clinical status. I should not be stopping suddenly just because I got this result. Now, these tools should be used on a case-to-case basis, tailored to the patient's condition. The results are specific to the patient and should not be generalized to others. The next is, critically ill patients often have more complex needs, so these tools may have to be used differently compared to other patients with infection but not critical. For example, in a septic shock patient where I detect the Enterococcus fecalis, which is resistant to vancomycin, the result is prioritized over a routine culture due to the need of a rapid decision right now. So this I cannot translocate to another patient where I get say a E. coli. I may not be changing much on those things. So I have to find out what my actions are, then it will be better. And it is important to regularly assess how these tools impact our outcomes. We must check our survival rates, our costs, if they are actually reducing or not. The whole objective is to improve our survival and reduce the cost. If I am not getting the cost and benefit, then it may not be a very good test for us. Now, finally, recommendations for using this tool should be updated as new evidence and better technologies are available, ensuring that the doctors are always using the most current and effective practice. Now, these are some of the algorithms that were shared. This is a case of severe community-acquired pneumonia. So you do the routine antigen for pneumonia and the Legionella, you obtain your cultures. Now, if my patient is having a risk factor of MDR and it is present, then I will start antibiotics as per my protocol, whether the risk is there or not. If my patient is having shock as well and is not having a risk factor, then probably I will send a molecular panel. In this case, I want to give the most specific antibiotic rather than going for a more broad spectrum. So if I can adjust this antibiotic by 2 hours, then it would be of real benefit to me. Whereas if I had waited for the culture, I would have waited for 72 hours. So it is in very specific case like this, where my patient is having no risk factors of MDR and is still in shock, then what antibiotic should I use? This could be a very important marker over there. Similarly, if I am using for bacteremia, for all the other methods, I am obviously not going to use PCR. If my bacterial culture is positive, then I have various options, that is availability of more specific tests like MALDI-TOF or non-availability of. If I am having neither gram stain or MALDI-TOF, then I have to go for a PCR to get some more idea. Now, if I am having availability to both the facilities, then I will do it based on the organism. The algorithm has clearly shown this. If it is gram staining is available but I don't have MALDI-TOF, in that case again I will do based on the specific organism. Whether I should go for a syndromic PCR or specifically only MAKE, I can go for that. So I have to keep this thing in mind before I'm sending out those tests. Finally, for candidemia, it is similar to the bacteremia. It is availability of the gram staining and the MALDI-TOF. If I don't have any availability for both, then I will go for syndromic PCR. But if I have availability, then I will do it based on the various findings. Thank you for your patience.